Hello, everyone. I'm Lauren May, Director of Research at the Marfan Foundation. Thank you for joining this global virtual conference brought to you by the Marfan Foundation and its divisions, the VEDS Movement and the Loeys-Dietz Syndrome Foundation. This session is being recorded. For our time together today, we will use the Q&A feature built into Zoom to field any questions you may have for today's speakers. Please select the Q&A tab on your screen to submit your questions at any time during the session, and we'll cover as many as possible at the end. We are excited to have with us today Dr. Juan Bowen, former director of the Mayo Clinic's Marfan and Thoracic Aorta Clinic and member of the Marfan Foundation's Professional Advisory Board, and Jan Lynch, a nurse and director of the Marfan Foundation's Help and Resource Center. Their session is titled Aging with a Connective Tissue Condition. Dr. Bowen, would you like to lead us off?
Yeah, thank you very much. Yes, I appreciate the invitation to talk today. And let me go ahead and share a screen here. So I think I am screen sharing, but I don't see my presentation quite yet.
Not yet.
Is it there now?
Yes, there you go, perfect.
Okay, well, again, thanks very much. I'm going to start with just talking about a patient I saw recently in my clinic. This lady's 56 and she has Loeys-Dietz syndrome. She feels well. She had imaging of the chest done for another reason a few years ago, and that imaging identified an enlarged aorta. She came to our clinic where her physical examination is normal. She doesn't have Loeys-Dietz physical characteristics, but she in fact did have a SMAD3 mutation. And her aorta was such that she did require a valve-sparing aortic repair, which went fine. But now that she's here, by the way, this is her preoperative imaging. So this is an enlarged aortic root, and this is the vascular tortuosity that's characteristic of this problem. So she had the vascular changes, but she didn't have the external physical changes. But now that she's been through this, she is 56 years old, and she's worried about, not worried necessarily, but appropriately concerned about how am I going to age now that I know that I have this, and does this change anything? So this is the topic that we're going to cover. Now, I'm going to say a few words about the science of aging, which is the word senescence is used a lot. And then we're going to talk about diseases, what you can do to reduce your risks. And then are there special considerations if you have either Marfan syndrome or another connective tissue disorder? So I think most of us intuitively know that aging is a large risk factor for chronic disease. And one way to think of this is that when you're young, your cells are fine. They don't have senescence. But over time, changes begin to occur in the cells and in their systems where they do develop what is called cellular senescence. And this turns into identifiable diseases. Eventually, the body becomes frail, and then eventually people die. But it's because of these changes inside the cells that one could call senescence. And there are some fundamental mechanisms behind this. And so these 3 or 4 basic problems inside the cells will lead to all these diseases. And another way to think of this is this long list of diseases that we deal with in older people, in a way, have sort of similar root causes. Now, in the laboratory, now it is known that you can take a normal cell and have it undergo certain transformations and turn it into a senescent cell that it now has sort of senescent pathways and biochemical reactions occurring inside the cell. And this is a list of the kinds of things that happen inside that senescent cell: signaling molecules, inflammatory molecules, genes that promote cancer, shortening of the telomeres and the chromosomes. And if you take a senescent cell and inject it into a young and healthy mouse, you can actually produce the kinds of changes that occur in aging. So you can age a mouse by injecting it with senescent cells. And in people, this would be a very similar pathway, where you can see here that a senescent cell is producing these various chemicals and activating these various pathways. And you can almost think of it as sort of infecting these organs and in turning this formerly robust person into a frail person. So another way to look at this is, if you look at the clock, this is how we age. This is a baby, of course, and this is a very old person at the end. And this looks like just the clock ticking, and down you go through the life cycle. But in fact, a biological aging is a little different, because this baby starts off with genetic factors that you cannot modify, but then other things happen in the lifestyle of the person. Person may choose to smoke, or to drink alcohol, or to be sedentary. There may be exposures to carcinogens, air pollution, you name it. And in the end, that person will develop a variety of diseases. So it isn't a fixed pathway like the clock. Another way to think of it is that you have one person who's age 70 who might be biologically a little younger, and another person who might be biologically a little older. And another way of looking at it is that traditionally in medicine, we have been trained to think of these diseases and to figure out how to diagnose and treat them. But in fact, we now are in a place in science where it may be possible to tackle the root causes and maybe get to the trunk of the tree, make changes there, and prevent some of these diseases that occur later on. So at least in animals, these are the treatments that are tried and actually work in a mouse model to reduce senescence and slow down aging. And you can see here that there's the potential that we might be able to do some of these ourselves. And the so-called senolytic drugs, they actually do work in mouse models, and they are being tested in clinical trials. So there's the potential that maybe in a few years, we will be able to take a medication that will slow down our aging. Now, we're not there today. And what happens today is that this is how long we live. Women, of course, live longer than men. They generally close to age 80. And if you look at what do we die of, 80% of us will die of either heart disease or cancer. And then, of course, there are other causes of death. This is a 2022 slide, and you can see here's a new arrival that wasn't there before. Now we have COVID-19 as an appreciable cause of death. So these things change, but the big two are heart disease and cancer. Now, let's take a minute and just look at the big factors in heart disease, because we're going to experience these ourselves. So heart attack is a big cause of death. Complications of high blood pressure, atrial fibrillation, many of you have dealt with this, and valvular disease. And again, so these are the big things in heart disease that can cause death. The heart attack is when a coronary artery undergoes a rupture of a vulnerable plaque and fills with a blood clot. And you can calculate your future risk of having a heart attack with a risk calculator that the American Heart Association uses, and we use it. So when I see a patient in the office, I do use this calculator and tell them, well, you actually have an 8% risk of having a heart attack over the next 10 years. But we can modify that by giving you a statin medication and make some reduction in that risk. So you can use tools like this. Now, one of the things you'll hear me say repeatedly is self-care. It turns out that in order to live healthier, self-care is at least as important as medical care. So remember those modifiable things. Well, you can improve your diet. You can increase your level of physical activity. You can avoid smoking and either eliminate or reduce alcohol use and extend your lifespan just by doing these things. Of course, sometimes you need, medication. Controlling blood pressure sometimes involves some personal health behaviors like losing weight, but you often do need medication. And same way, if you can't control your lipids through diet, which is hard to do, then you might need to take a statin. Now, I'm going to take just a second, because heart attack is so common, to just remind you that there are typical heart attack symptoms where you're at home, all of a sudden you get a squeezing bad central chest pain, and that's your heart attack occurring. But sometimes the symptoms are a little atypical, might be shortness of breath. Sometimes it's an aching in the jaw. I remember when my dad had his heart attack at age 88, he called me on the phone and his arms felt heavy, but he wasn't having any chest discomfort. And the reason I'm reviewing this with you is because if you don't do anything right away, you run a high risk of experiencing sudden death from an arrhythmia. That's why they have defibrillators and portable defibrillators everywhere. So when you have this, you don't, wait and see what happens or have a family member drive you to the emergency room, but you call 911. So you get the right pre-hospital care. Now, we'll shift gears and talk about hypertension, which can hurt you through eventually producing heart failure, eventually causing a stroke, and eventually wearing out your kidneys. And stroke risk increases with age. The lower your blood pressure, the better off you're going to be as you age. You will have a lower stroke risk. And it is true that, lowering blood pressure reduces not only the risk of stroke, but the risk of heart failure, and to some extent, the risk of heart attack. How do you reduce your risk? Well, it's the self-care thing again. Most of the risk reduction from hypertension comes from personal health behaviors, but sometimes you need medication. And many people with high blood pressure require 2, 3, or even 4 medications. We're going to talk next about atrial fibrillation, which many of you have had, where your nice cardiac rhythm, which is you can see down here, becomes disorganized because the upper chambers are no longer beating in a coordinated fashion, but rather irregularly. And unfortunately, this produces the risk of clot formation in that left atrium. And this can travel through the circulation, go into the left ventricle, out the aorta, and up into the brain, where it can lodge in an artery and the person has a stroke. So this is a big complication of atrial fibrillation. And the treatments are evolving rapidly. Rhythm control is now possible in many, many people, sometimes with medications, but more and more with catheter ablations. And where you cannot achieve rhythm control, the heart tends to beat fast in atrial fibrillation. So slowing the heart rate with beta blockers or other drugs is another very good treatment. That blood clot problem is there, and many people require anticoagulation. But now there's the Watchman device, which is a tool. I'll show it to you right here, a left atrial closure device that if you have this placed in the cath lab, this can actually control the risk of blood clots getting out of that left atrium and can eliminate the need for an anticoagulant. But many people will need an anticoagulant. Ultimately, a lot of people in today's world with widely available electrophysiology services can have a catheter ablation and eliminate the problem of atrial fibrillation. Now, talking about heart valve aging, one of the most common heart valve problems in the world that affects not only people with Marfan syndrome and related conditions, but also really the general population, is when the mitral valve is structurally weaker than it should be, which causes the valve to balloon and leak, and ultimately leak severely. And this is mitral regurgitation. Here is an echo picture where a nice mitral valve on the left closes fine, doesn't leak. Here's a mitral valve that is weak, and you can see that it kind of bows and doesn't have a nice closure of the doors. And then within Doppler image here, you can see that there's a little blue jet that leaks back into the left atrium. This is very slight, but it can be severe. And this person could even need an operation to repair the valve. Now it's known that mitral regurgitation has stages all the way from mild to severe. And the big message is that if you wait until symptoms develop, it's often there's not a good outcome. But somewhere in here in the earlier period where mitral regurgitation is significant, but not yet causing symptoms, there is the opportunity to repair the valve. And the valve is now done with very standard repairs that are easily done by experienced cardiac surgeons with good results. So it's nice to know that this problem can be helped. The other bad valve in many of us is the aortic valve. This is a nice normal aortic valve, but the aortic valve can go bad. Some people are born, 1% of all of us are born with a bicuspid valve, a defective valve, but even people born with a normal valve can have degeneration and calcium buildup. And this is what the echo would look like in a normal aortic valve, which you can see it opens nicely. But here's one that is calcified and deformed and really barely opens. And now, same as with mitral valve disease, there are stages of this. And again, if you wait until symptoms develop, you might not have a good outcome, but the time for intervention is somewhere in here before severe symptoms develop. And traditionally, the valve has been replaced surgically, but as most of you know, now there are catheter techniques. So here's a catheter technique where a valve is being placed from inside the heart without the need for open heart surgery. And this is now a standard successful treatment that is widely available. Let's switch to the aorta because many of you have problems with your aorta. This is a normal thoracic aorta with a lot of elastic tissue, which is yellow here, and a nice normal pulse wave. But with aging and with connective tissue disorders, these elastic fibers will fragment and the aorta will stiffen. And now the mechanical properties of the aorta are not normal and the aorta enlarges. So this is caused by both normal aging, but also by connective tissue disorders. Now these are normal aortas, 16-year-old, 30-year-old, 42-year-old, 64-year-old. But if you've got a connective tissue condition, you might have an aorta that looks like this, like the 64-year-old when you're 20 or 25. So in a way, the aging changes are similar to the age changes in connective tissue disorders. Now, so that's heart disease, but as we said earlier, the other half of us are probably going to die of cancer. And you can't affect your oncogenes. You're born with these, but many of us have a bad mix of cancer-producing genes that we're born with. But one thing you can do is not expose yourself to tobacco, to control oncogenic viruses like HPV as much as possible. And some diets are known to be more associated with cancer than others. So cancer risk, again, of course, increases with age. And some of these solid tumors can be screened for. We usually don't screen or don't have screening tests for leukemias and lymphomas. But that would be the situation with cancer. So solid tumors, blood malignancies. Now, Jan is going to say more about mental health, but as all of us know, there are many mental health problems in the population consisting of usually this list. Again, your personal health behaviors are going to determine a lot of how well you age, and we already addressed these. The American Heart Association has these in a little document that they call Life's Essential 8, and I won't repeat them because we sort of just talked about them, but it's everything from smoking, adequate sleep, I didn't mention, the appropriate diet, appropriate physical activity, control of blood sugar, control of weight, control of lipids, control of blood pressure. And in their document, they didn't address the psychosocial aspect of life, but of course that probably should be in there as number 9. Now, that's self-care. If you do the Life's Essential 8, you're halfway there. But many of us need medical care. We all need medical care. we all should have access to primary care. And I recognize that not everybody does, but we should. And this would include a periodic examination, the type of blood test that can pick up problems like anemia or diabetes, and the cancer screening that can be done for colon, for example, mammograms, and vaccines, which unfortunately have developed sort of a political component or aspect to that. But vaccines are life-saving and should be done. And then all of you not only require regular primary care, but actually specialty care. And pretty much almost everybody, I would say, who with a connective tissue disorder should have some access to a specialty clinic where they understand your condition and can do the appropriate surveillance tests and direct you to treatment when it's necessary. Now let's talk just a little bit about Marfan syndrome and related conditions. Dr. Puritz wrote this editorial some years ago, how research does pay off and does lead to improvements in life expectancy. Because in the past, we did not understand the biology and we didn't really have good tools. But now we understand a lot of the genetics. We have reliable surgery. We have reasonably good medical treatments. We have animal models. We even have human trials in a lot of these diseases. And we also understand that it isn't all Marfan syndrome, but it's other conditions. So we're way ahead of where we used to be. And this translates into better survival. So these are now currently, Marfan patients can be expected to live a near normal lifespan, where a generation ago, this was not the case. Now, what additional risks do you have because you have a connective tissue condition? Well, another way of saying this is it possible that the mutations in your tissues and in your signaling pathways might increase your risk for either heart disease or cancer. And this is very plausible because many of you have a TGF-beta pathway disorder. And the TGF-beta pathway is a universal pathway in the cells that signals many things and participates in the formation of cancer cells. So this is an important question. We talked a little bit about heart disease. Do you have an increased risk of heart disease because you have these disorders? And the answer is, it's not known if you have a higher heart attack risk or higher hypertension risk, but you definitely have a higher risk for atrial fibrillation and other rhythm disorders, and you definitely have a higher risk for valve disorders. So special focus on these. Now with this is what you can do about it, the self-care. I'm just going to highlight the physical activity because this is one that is part of self-care, but many of us are sort of afraid to do if we have an aortic problem. But Dr. Braverman to the rescue. This document is available in the Marfan Foundation website, and it talks about, how can you safely exercise when you have one of these conditions. There are mouse studies and increasingly some developing human information and evidence, but we know that being sedentary is not healthy. We also know that extreme activity is not healthy, but somewhere in the middle is where we should aim as far as physical activity. Now, I'm just going to say one more word about the cancer risks because it's possible that, not known completely because we don't have full research in this area, but there was a study from Taiwan several years ago looking at Marfan patients, Marfan syndrome in their population, and there appeared to be an increased risk of head and neck cancers and bladder and kidney cancers, so urologic cancers. But the reason I use the word possibly is this is one study in a Taiwanese population. It's not clear that this is going to be there for the entire world, but it's a concerning finding. And then again, we'll have all of you, of course, know that these three problems are more prevalent in Marfan syndrome and in related conditions, and Jan will address this a little bit more. So again, the way you handle this is the way you handle everything else, with good self-care, access to primary care, and sometimes you might need a professional help with both mental health and chronic pain. So in summary, we talked about self-care, and I said that's about half of the benefit. So please do that. And then these are the components of, primary care can help you to reduce your cancer risk through screening. It can help you reduce your heart attack risk through statins, for example. Your quality of life can be made better, control of pain and other symptoms. But you're going to need specialty care, particularly for your cardiovascular and vascular problems. Many of you will need specialty care for the eyes and the musculoskeletal system. So your needs are more complicated than the average person in the population. But fortunately, for many of you, we do have the services available, recognizing that we're not there yet in terms of having them available for everybody who has these conditions. So I just want to mention that a huge resource is the Marfan Foundation website, which now has a wealth of information in the form of many things, webinars, video clips, lots of things. So please use this regularly. This is an important peer and support group for you. And my take-home points for today would be, the health risks, of course, increase with age. You can do a lot with self-care. We all need primary care. And of course, those of you in the audience and your family members also deserve and should get lifelong appropriate specialty care. So these are the Mayo brothers who founded the Mayo Clinic. And I'm sorry to say that most of the year that statue looks like this up here in Minnesota. And I want to thank you very much. So on.
Thank you, Juan. Appreciate all of that information. And now I'm going to focus on the mental health side of aging. I must say that I've learned so much from the people that have come to me to the Help and Resource Center. I'd also like to give credit to my 50+ virtual support group who have made me wise and comfortable with what mental health issues they are suffering from. And also Melissa Flint, who is a psychologist and on our professional advisory board. She actually did the general session at the start of our conference. And if you weren't able to attend, by all means, check that recording out. She is wonderful and has served as and she helps us with people in our community, and has also done a number of YouTube videos on mental health and having a chronic condition. So be sure to check those resources out on our YouTube channel. So when coping with a chronic condition like a connective tissue condition, a person can lose sight of other aspects of their life and really just more focus on the medical side, and understandably so. They lose sight of perhaps their mental health, their social side, their emotional side. And so their life becomes imbalanced. Then add in the issue of having anxiety, depression, and anger. Adding that into that further destabilizes the individual and how they're coping and doing with their life as they doing with their health and well-being as they grow older. I'd like to do a few definitions and then a few facts that we know from research before I move on to fiercely guarding against depression, anxiety, and anger. Because that is how Melissa Flint phrases it. And it's a beautiful way of thinking about that we are protecting ourselves against anxiety, depression, and anger. A few definitions, not in depth, certainly. Depression is the feelings of severe despondency and dejection, often accompanied with physiological symptoms, lots of different ones like inability to sleep, inability to eat, inability to socialize, inability to work. It's not just sadness or being temporarily set back. Anxiety is more than just the day-to-day ooh, I hope this doesn't happen. Ooh, I really wish it goes well today. It's a strong feeling of worry, nervousness, unease, and it's usually associated with an uncertain outcome. And certainly all of our community who have connective tissue conditions feel that uncertain outcome, whether it be for their procedures, they're receiving the diagnosis, the surgeries, and so certainly anxiety sets in. And anger is that very strong feeling where you may act out. It's not just being temporarily upset with someone, it's rather feelings of hostility and venting them inappropriately on others, whether it be through hostility or passive aggression. It's not, as I said, not just being temporarily upset. So I'd just like to give some facts here related to anxiety, depression, and anger. Experiencing a chronic condition puts a person definitely at increased risk for developing anxiety and depression. That's a fact. It's in the literature. Persons with chronic pain are 3 times more likely to develop symptoms of anxiety. There's a high correlation. The daily demands of dealing with a chronic condition can build up over the years. So here we are, we start out young, and as we age, those daily demands, as many of you have experienced, build up over the years. And then fears begin to creep in. Loss of mobility, concerns over safety, employment, independence, feeling a lack of control. There's so many different ways that we're affected that cause this anxiety and depression. And certainly those issues that Dr. Bowen just talked about with aging, the aging and illness and the condition can work against one another. Now, anxiety and depression can look different in someone with a chronic, lifelong condition. And certainly you can add in the chat, if you care to share how you feel your anxiety and depression is expressed in your life, so that others, this is not a all-inclusive list, and you might be able to help someone else who has experiencing anxiety and depression, and how they express it might be something similar to the way you express it. Here are some examples: excessive worry about physical health, panic attacks about prognosis, intrusive thoughts about dying, chronic irritability, trouble sleeping due to worry, trouble discussing your physical condition, irritability about physical health, shame and self-blame about your condition. And there's a lot out there in the literature about that specific topic. Nightmares about health, avoiding treatments that cause anxiety, anticipatory panic attacks about a treatment or a future prognosis, and thoughts of suicide because you believe that your condition makes life worthless or too painful to handle. And then, of course, that's the anxiety and depression, but the anger connection is that there's much that many people consider anger is simply, essentially, expression of fear. This isn't fair. I'm angry at my life, my body, my physicians, a higher power. The anger goes diffused to every possible person or situation. And we'll go into the key is learning how to not disperse that anger. And we'll go into that when I talk about the fiercely guarding against depression, anxiety, and anger. So Melissa Flint uses that phrase. It's not mine. Fiercely guarding against depression, anxiety, and anger. And it feels good, doesn't it? Like you're protecting yourself. It's not just, how can I not be anxious? How can I not be depressed? It's, I'm going to guard. It feels like you're actively doing something about it. So I'm not covering all of them. And again, by all means, add into the chat box ways that you fiercely guard against anxiety, depression, and anger. The first one that has been out in the literature and many people in our community talk about: meditation, prayer, mindfulness. It's basically those that I've just mentioned are unwrapping yourself from the condition, separating yourself from the condition. It's not just pretending. You really are literally getting yourself away and helping yourself. There are apps for guided imagery, and people talk about mindful moments. I like that expression. You don't need to do this for hours on end. You could have a mindful moment. We actually participated at Stanford University in a powered relief study, and people in our community participated. We partnered with them, and what they did in the study was they met for a session, and then they had subsequent surveys that they filled out. It's finished, but I happen to know of one gentleman in our 50+ support group that has been raving about it. And so you can go on the Empowered Relief website through Stanford, and they have helpful resources for you that can help in this regard. The practice of gratitude, and this is one that I feel like we all need to practice the practice, because it's something we all talk about. I need to be grateful. I want to be grateful. I am grateful. And it's really a practice that we know about, but I think that deliberate practice is certainly in order. It can change your entire countenance. People use gratitude journals. They wake up in the morning to do gratitude meditation. There's many different ways to do that. The practice of seeing a mental health professional. So many people have come to me and told me, yes, a mental health professional has made a significant difference in my life. It struck me how they feel so strongly about it. We do have our own mental health page. If you go to our website and put in mental health resources, our social worker has put together an amazing page of so many different resources. One of them is how to find the right mental health professional, because I've heard many people come to me and say, he's not working or she's not working. She thinks I'm like a cancer person. I'm not, so you got to make sure that several people have shared with me that they briefly met with the healthcare, the mental health professional to make sure that they're the right fit. So that's I've heard great feedback from people in our community. Juan covered the practice of self-care. That's another one that we need to practice, the practice that we need to practice, because we all know that we should be doing those things, but that's good for us to go moment by moment and practice self-care. Another practice is acknowledging successes, pat ourselves on the back, like it's not, I know I see it in the Help and Resource Center. People feel badly about themselves and are done in. And I think if we can acknowledge more frequently about our successes, because there are many, rather than what else didn't I do right? What else can I do? That's a powerful, fiercely guarding against anxiety and depression. Our support groups, and there's others out there too. I know people are on Facebook support groups and other support groups through other organizations that work for them. We have mostly monthly ones, and not only do they serve as a connection to the group, but also on many of our virtual support groups, because people become regularly, they become one-on-one connections. They meet outside on the phone and in person. So it's a beautiful way. And I know people have said to me, I'm not a good support group person, but if you try it once, that's might give you a little clue as to how it could work. The practice of actively building your team, and I'm not referring to the medical team, I'm referring to that team that's supporting you and loving you and being there for you, whether it is people from church, whether it's family, friends, neighbors. building that little team of people that you know you can count on. I like this one. It's the practice of rising above self-defeating thoughts. We feel badly, of course. We all feel badly in our lives, but trying to shush them away or changing them. And maybe you can put in the chat some ways that you change a self-defeating thought. Just as an example, I hear, so I didn't ask the right questions. He or she didn't give me the time in the doctor's office. Rather change that thought in yourself. Next time I'm going to have the questions ready. And if he rushes me, I'm gonna say, could you just give me some more time? Or how can I reach you after the appointment? I'm coming to the end, Dr. Bowen, and I'm getting there. Self-compassion is another practice that we want to practice. We are so good and honor and respect other people, and we deserve that honor and respect to ourselves. And another practice that I found interesting, and I hear many people saying they wish that they had a crystal ball and could look into their future and know everything's going to work out or how it's going to work out. And I think the acceptance of that we don't have a crystal ball. Certainly we can plan. We don't need to just throw our hands up. Certainly we can anticipate. And the whole anger issue is oh my gosh, it's such a huge issue. I feel inadequate to express all that's all around anger. I can tell you a few things. Healthcare professionals often advise that you see a mental health professional because anger is so deep sometimes and so hard to understand. And we feel like, let's just lash out and I'll feel better. And that's not the solution. Finding out where that anger is coming from and taking control. It's not easy. Anger is an okay emotion and part of life, but the control and navigating how to best handle it. And sometimes that's difficult to do on your own. There's a book that you might consider looking at. Alana Jacqueline does a book on surviving and thriving with an invisible chronic illness. And I think that's it for now. I'll wait for Juan to come forward, Dr. Bowen to come forward, and we'll address your questions and answers. And please come to the Help and Resource Center anytime.
Well, Jan, can you hear me okay?
I can.
Yeah, that was great. And the only thing I would add is that when they've done studies on, who's happy in the world, which countries are the happiest countries and which people are the happiest, well, the message that comes through is that it's the people who are socially connected are the ones who are the happiest. So isolation and loneliness are bad, and connecting with others, whether it's family or friend groups, but those people who manage to sustain these connections are the ones who do better in life.
Oh, yes. Thank you for mentioning that, Dr. Bowen. I hear in our support groups and at the Help and Resource Center, I'm so happy we connected with the Marfan Foundation in this way or that way. Our walks are getting tremendous reviews and raves about connecting with others in person, so.
Great. I'd like to thank Dr. Bowen and Jan for so eloquently addressing such an important topic for our communities. Members of our audience have submitted several questions for Dr. Bowen and Jan, and we will go through those now. Dr. Bowen, could you please elaborate on how a heart attack and a dissection might feel different for someone?
Yeah, that's a great question. So unfortunately, they sometimes don't feel different. And the textbook says that dissections feel like a tearing pain, either in the central chest or sometimes in between the shoulder blades. And you do hear this from people, but you also have people who describe them differently. And some of this has to do with where the pain fibers are in the aorta. They're on the outside of the aorta, and not all the dissections are going to reach the pain fibers in the same way. So I think a reasonable way to handle this is to worry about pains that are bad, something completely new that you've never ever had before, somewhere in the chest, up into the neck, to the jaw, the arms, but something that's clearly new to you and feels bad. Sometimes that's what, you know, all you can say.
Thank you. On your slides, you had a short list of self-care items: diet, exercise, tobacco, and alcohol. Are those ranked in order of importance the way you had them?
Oh, well, I don't know. That's a good question. I think, I don't know. I think you could consider tobacco to be maybe the worst. People who smoke, that's 10 years off of your lifespan right there. So for most people, you'll hear about the 95-year-old who smoked all his life and et cetera. But for most people, it takes 10 years off of your lifespan.
Thank you. For those who maybe aren't feeling as sharp as they used to be, or are feeling a decline in their executive functioning, is there advice that you could offer on how to slow that progression, or is it even possible to gain any of that loss of executive function back?
Well, there's an understandable, I mean, I'm experiencing this where you don't have quite the memory that I used to have. I might walk into a room and, oh, why? I know I'm here for a reason, but why did I walk into this room? That's simple forgetting, but things that are, not simple forgetting, or for example, getting lost driving to the store, that would not be simple forgetting. That would be a more serious problem. Or not remembering a conversation that you had 5 minutes or 10 minutes ago, that would be a more serious problem. But I think for those of you who are simply just a little more forgetful than you were, and that's all there is to it, just accept that. That's an expected thing with aging. Don't do the supplements and all those things. Probably honestly, the best thing you can do is physical activity and go back to those essential 8 items.
Juan, Dr. Bowen, I know that I've come to you a number of times about the supplements for people, because that is a question that comes up regularly for people, whether to improve their health or also to improve the strength of their connective tissue condition. That comes up regularly to us at the Help and Resource
Yeah.
Center.
Yeah, and so taking a multivitamin, I think, is okay. Vitamin B12 is a particularly good vitamin to take as people age, because many of us become deficient. But the idea that you can, buy a collagen product and that somehow improves your collagen, no. The FDA requires drugs to go through clinical trials and to demonstrate efficacy and to demonstrate safety, but supplements are regulated as foods. And most of the time they're not hurting people, but there are many well-documented cases where they have hurt people because there was a carcinogen or some toxic thing in that product, despite the glossy advertising, et cetera. So I would say just save your money, don't do those things. Instead, do the Life's Essential 8.
Life's Essential 8. Thank you. Are cardiac ablations safe for individuals with VEDS?
Well, that's a good question. Yeah, that it would be kind of an individual discussion, because the mutations can vary from, significant mutations to very bad ones where there's extreme tissue fragility. So there's not enough literature to know for sure, but I know at least in our vascular practice, we try very hard not to do things for the people with the worst mutations with the most extreme tissue fragility. Now, sometimes you wind up doing things as emergencies, but in general, that's to be avoided for those people.
Yeah. What are the options when the heart has calcified?
Well, so calcification of blood vessels is a expected change with aging, that all of us develop calcium, some more than others, but there's not a lot you can do about it. If your biology is such that you're going to develop a calcification, you're going to develop calcification, and I'm not aware of anything that you can really do to prevent that.
Okay. Can lifestyle changes reduce the risk of blood clots and atrial fibrillation?
Yes, it's a little hard to prove, but one thing for sure is blood pressure is related to atrial fibrillation. Another definite connection is alcohol. Many people find that alcohol triggers their atrial rhythm problems. So yes, generally the answer is yes.
Okay, thank you. Does the increased risk of cancer that you spoke of in your presentation include squamous cell carcinoma?
Well, squamous cell carcinomas can occur lots of places on the skin or in many organs. So if this Taiwanese study were to be repeated elsewhere and confirmed, many of those, they call them aerodigestive, so upper airway ENT, are squamous tumors. So the answer would be yeah.
Okay. And the last question we have, it's from someone who is 74 and diagnosed with Marfan syndrome with no heart or aortic symptoms. So other than the 8 lifestyle recommendations, is there anything else that they should be doing?
Well, this is a very, very fortunate person with a very unusual and mild disease, because that's very uncommon. So congratulations, and it sounds like you're doing fine. Keep doing what you're doing.
We actually did just get one more question. Should cancer be treated more aggressively in LDS or other connective tissue conditions?
Well, that's a difficult question too, because there's so many cancers. It's so heterogeneous. The treatments are so different now. As a big, big theme, the whole field of immunotherapy for cancer wasn't there, even 10 years ago, and now it's a big thing. So I think your best bet is to go see a cancer specialist and have a discussion about your own personal situation.
Great, that's a great recommendation. Actually, one more. What about vitamin C for VEDS?
Yes, not proven. It's biologically plausible that it might help with maintain the integrity of collagen. It's a harmless thing to do as long as you don't overdo it. I did have one patient in my career who thought that vitamin C was completely harmless and took so much of it that she developed a vitamin C kidney stone on an airplane halfway across the Pacific. So I think vitamin C is fine, but stick to the regular doses.
Okay. Many thanks to those in our audience who submitted questions, and to Dr. Bowen and Jan for so thoroughly answering them. If you have non-urgent medical questions, that you have not had answered or would like more information, please send an email to our Help and Resource Center at marfan.org/ask. Again, thank you, Dr. Bowen and Jan, for speaking to our community today. Thank you to our audience for joining us. Have a great day.
Thank you.
Thank you.